Thank you so much for that introduction. I appreciate it. I'm really happy to be here today. Um, I am happy to talk about our study that was recently funded by the APDA, looking at low utilization of deep brain stimulation therapy among minoritized individuals with Parkinson's disease. I'd like to thank my co-investigators, Dr. Charles Ellis, who is an expert in health disparities, and Dr. Molly Jacobs, who is an expert in epidemiology and statistics, and a special acknowledgement to my doctoral student, Ms. Bryn Taylor, who was instrumental in conceptualizing this study. So, what we know about deep brain stimulation in Parkinson's disease is that it's a neuromodulatory approach to treating many of the motor symptoms very effectively in PD. It's been approved for nearly 3 decades to treat tremor, and since 2002 to treat other motor characteristics of PD. In terms of its rate of implantation, there are approximately 12,000 implantations per year across different diagnoses, according to a recent analysis in 2019. When we look at data from our center, we've seen a continuous uptick in the rate of implantation since its FDA approval in 2002, from a rate of approximately 4 in 2002 to well over 100 as of 2018. However, when we look for our local data in terms of who's getting implanted, we can see that approximately 90% of those that are implanted are white, and that's in our local cohort. And a recent systematic analysis of large-scale DBS studies showed that 85 to 98% of participants were white as well. That same study looked at 4 key disparities in DBS utilization factors. The first one being a female gender, low socioeconomic status, geographic location, and lastly, being of a minority race were key factors in the disparities of utilization of DBS. Our study is focusing on minority race. Some traditional reasons why people of minority race might have health disparities include lack of usual service provider, perhaps a lack of insurance, medical mistrust, and lack of available services. Other studies have identified other factors, including social or cultural biases when considering care, and a few other factors that may contribute to this, including reliance on Medicaid or other comorbidities. So our study really aims to look at whether these range of factors potentially contributing to these observed disparities in DBS use. And specifically, little is known about the long-term impact of initial disparities in the use measured by health-related quality of life measures, which are known to differ by race and many neurologic conditions, including PD. This table from the National Institutes of Health identifies different levels of influence as well as domains of influence across different domains in the disparities and utilization of healthcare. So the goals of the study, we had 3, were to first identify patient predictors for referral for DBS using a large clinical database. We also aim to explore patients' perception of key factors that drive the acceptance of DBS and determination of the specific factors that differ by race using a mixed methods approach. And lastly, we aim to examine racial differences in health-related quality of life among individuals who have received DBS to further determine the long-term effects of acceptance or lack of acceptance of DBS in Parkinson's disease. We hypothesized first that being Black, utilizing Medicare or Medicaid, and having more than 2 comorbidities and longer duration since PD diagnosis would be negatively associated with referral for DBS or receipt of DBS. Secondly, we hypothesized that common themes impacting PD-related healthcare would be identified and allow us to identify factors that healthcare providers can consider or practices they can implement to improve access and utilization of PD-related healthcare for Black people with Parkinson's disease. Last, We hypothesized that receiving less than 6 follow-up neurology visits, having less than 1 rehabilitation therapist visit, including physical, occupational, speech, or swallow therapy, in the 6 months post-surgery, which is at our institution the recommended standard of care, would negatively correlate it with health-related quality of life. And so in order to address these hypotheses, our methods are a mixed methods approach using both retrospective and prospective methodology. So in the first step of our project, we're going to utilize a retrospective review of a large IRB-approved database at our institution that has approximately 6,900 people with Parkinson's disease enrolled. So from this, we're going to extract demographic characteristics, including age, sex, race, ethnicity. We're going to collect clinical characteristics such as duration of diagnosis, other comorbidities, medications, and rehabilitation referrals. We'll collect information regarding their DBS disposition, whether they have DBS or not, but also whether they were referred for DBS consideration, whether they were accepted for DBS consideration and got it or did not get it, and then also geographic location at the level of a 5-digit zip code. Inclusion criteria for this part of the study simply includes diagnosis of Parkinson's disease, and exclusion criteria would be if they had had DBS performed somewhere outside of our institution, or they had other neurologic conditions such as stroke or multiple sclerosis or those sorts of things. From this initial retrospective review, we will extract participants who have agreed to be contacted for participation in prospective research. And for those that have agreed, we estimate this to be approximately 500 of the original 6,900. We will ask them to complete online surveys about illness perception, Parkinson's disease questionnaire, and treatment expectancy form that is related to DBS. So what they thought would be improved with DBS and sort of just how they thought DBS might help or alleviate their symptoms. They'll also complete at the end of that online survey a form whether they agree to participate in a follow-up semi-structured interview. For that leg of the project, we're aiming to enroll 40 individuals, and basically there's 4 groups. These are all non-Hispanic individuals that are either Black or white that have either received DBS or not received DBS. But all of those people will have been referred to DBS. So they either got it or did not get it, but all were referred for it. These interviews we anticipate will take between 30 and 60 minutes. They'll be completed via Zoom, and they'll include the following 5 questions. All right, so first we'll ask them about how they first heard about DBS surgery. Was it a primary care practitioner? Was it a general neurologist? Or was it when they were at our center with a fellowship trained movement disorders neurologist? Why did they choose or not choose to have surgery? So were they not approved by a multidisciplinary team, or were they approved and they chose not to do it? So what went into that decision-making process? If they were comfortable with their decision to receive or not receive it, and of course, why or why not? If they're still comfortable with that same decision, whether they are still comfortable, or if not, why not? And then whether they did or did not receive DBS, did their treatment choice meet their expectations? So did DBS meet their expectations? Did the decision not to have DBS meet their expectations? In terms of statistically analyzing the data, we will utilize the following. And again, Dr. Molly Jacobs is the statistician on the study, so she can provide a lot more information than I can on this. This is my very brief description of her extensive description of the analysis. So to address hypothesis 1, we'll utilize descriptive statistics and stratify participants by race, ethnicity, and sex. We'll use an analysis of variance for continuous variables, chi-squared for binary variables, and look at the likelihood of receiving DBS using an unconditional logistic regression. Hypothesis 2 will utilize a grounded theory approach to interviews. So this is the idea that you might not need a huge number of participants, but you reach sort of this idea of saturation in terms of the themes produced during the interviews to identify basically to identify hypotheses or factors that you can then either test or implement in your practice. And then hypothesis 3 will use we will compute quality adjusted life factors. We'll look at natural language processing and machine learning approaches and predicted covariates that can be tested in our general linear model for racial differences. So where are we now in this project? So far, we've received IRB approval, which is always a great first step. We have access approval for the large database to access all of those records. And we are training our research assistants to basically pull the data that we want from different locations, including the database and their electronic health records. And our next steps will be to implement that data extraction, survey distribution for the prospective patients. Then we'll conduct our semi-structured interviews, and hopefully beyond that, we'll be entrenched in our data analysis. So again, I'd like to thank my co-investigators. I'd like to thank the APDA for funding this important research, and thank you for your attention tonight.